Next we've got Jag. We've just changed the order around slightly. So Jag Mundra works with PCNs nationally to promote best practice using the 3 roles to tackle health inequalities through population health approaches and evaluating impact. Over to you, Jag.
Great, thanks everyone. And I've just got to say, what a wonderful set of presentations, and I feel so inspired, and I've got so many more ideas, and I love to see the connections behind all the work that everybody's doing and the things that I'm seeing on the ground as well. So a little bit about me. So my name's Jag, and I work for an organisation called the National Association of Primary Care. And over the last however many years, quite a few years, we've been working directly with primary care, but always looking outwards, to try to get people to start doing more health improvement, addressing inequalities, starting projects, and working with the very limited time and energy and resources that people have to try to get something going and then evaluate whether it works. So to date, we've worked with probably closing in on about 15% of primary care, and we're currently overseeing around 300 different population health improvement and inequalities projects. Some very small at idea stages, and some very big that are kind of changing the way that care is delivered across an ICS and a place as well. So I've also got a special interest in the data side of things. So in kind of telling this story, I try to intersperse it with real data from real projects and from the analysis that we've done. From an analysis perspective, we've kind of used data from closing in on about 1 million patient records across those range of projects and practices and PCNs as well. So what I'm trying to do super quickly, to leave time for questions at the end, is try to answer 3 questions. The first question is, what are the main health improvement needs in my area and every area nationally? Second is, what interventions have the biggest impact on health and demand? And the third thing is what simple things can I do to get started with this agenda with health improvement? And so please put questions in the chat, and I'm happy to answer them. So the fact that the first of those 3 questions, so what are the top health improvement opportunities in your area? So as I mentioned before, we've looked at lots and lots of patient data to help answer this question. And over, let's say 2 or 3 years ago, we would do a lot of bespoke analysis with linked data sets and primary care data sets to try to discover what the main needs were. And we've got to the point where we've done this so many times now, we always see the 4 things on this slide appearing at the very top of the list. The order might change a little bit, but areas are different. They're unique, but they're not that unique. So what you see on the slide is what the data tells us are the main health improvement needs in every area. I'll step through each one in turn. So when we talk about obesity, we're really talking about diabetes, pre-diabetes, diabetes, and obesity. And in an average population, somewhere between 30 to 45% of patients will fall into that category, will be overweight. When we talk about anxiety, we're talking about low-level mental health issues and SMIs as well, and roughly 25 to 35% of patients will have 1 or more anxiety code on their record. And we know that that's an underestimate because it's coded well, but not always that well. When we're talking about frailty, as much as 20% of the population, that can vary quite a lot, can have mild, moderate, or severe frailty. And the reason, so that's a smaller proportion than the others, but the reason why frailty is so critical is by 2050, we're going to see a very, very large increase in the number of people over 65 and an even larger increase in the number of people over 80. And also what we do know is that with this new research that shows that working with the severely frail, you can really stem working with the mild and moderately frail, you can really stem the deterioration towards severe frailty as well. And then finally, with respiratory, you can tell that I'm an analyst because that's a jumble of smoking, COPD, asthma. Obviously, air pollution is a population health need. Roughly 30 to 35% of patients will still be smoking, have COPD, and or have asthma as well. So there's a respiratory grouping here. So one thing that we've learned to do over time to help people get started with projects, and this is borne out by the data as well, is to link together need with demand. And what you can see underneath each one of those titles is how, not just how many people fall into each of those categories, is also how much more GP contact people in those categories are responsible for. People who are overweight or obese, they're often responsible for nearly double the number of GP contact, and that's the same for people who have low-level mental health issues. Frailty is even more, and respiratory is a little bit less. So I guess a handful of really key messages from this slide. The first is we have to get better with data. And I'm passionate about data myself, and I do really love that the new data that's coming out, particularly from linked data sets and dashboards and AI solutions. But in parallel to that, I think there's almost another group of people who feel quite overwhelmed by all of those resources. And I think the message is that it's okay, even if you've just got 20 to 25 minutes in a month and you're looking at a litany of resources that are available to you, it's okay to just pick a group of patients in one or more of these categories and call them up and find out what their needs are. So it's a little bit like, we've got some great data solutions that are a bit like a calculator, but this is just the kind of basic mental arithmetic that's also useful to do. So this is not to say that those solutions are not needed. Those solutions are going to be the kind of the bread and butter of how we do population health management. But there are some easy ways to pick out low-hanging fruit using methods like I'm talking about here. So the first thing is that, yeah, you can, if you like analytics, look at it, but it's okay. It's also okay to just kind of use your instincts. Your instincts are data too, and you can just pick a group of patients from one of these categories. We do help people with searches to how to identify patients who are kind of rising obesity, anxiety on their record, low clinical complexity as well. So to really help target that proactive support that other colleagues and other presentations have spoken about, but and also a word on inequalities as well. When we're doing large-scale inequalities work, it's possible to use deprivation coding in EMIS using the Townsend score, or by bringing in IMD in the index of multiple deprivation data into System 1. That's a more complicated search, but it's possible to get a deprivation code or deprivation indice against every patient to really help you target that support as well. And often when we're doing deprivation, or when we're doing inequalities work, we just create a search for patients who are living in the most deprived postcodes, and you naturally find more obesity, anxiety, and respiratory in those postcodes as well. So that's just, so I get the main message here is simplifying the analysis, and the final one is the one at the bottom of the slide. Prevention really is the best way to reduce growing GP demand. And this next slide really just expands on that point slightly. It's a very, very simple bit of analysis, and it's quite crude, but it's deliberately simple just to illustrate that trend. On the x-axis, you've got BMI. On the y-axis, you've got GP appointments. And what the chart is basically showing you is that per point increase in a patient's BMI, you can see a corresponding increase in GP demand, to the extent where even patients in the healthy range between 20 to 25, that's the per point increases it correspond to rises in GP demand, even in that kind of range as well. And what we're saying here is that this isn't this. I really like, Dan, that it's a really that powerful poster that you put up about obesity. This isn't about obesity. Obesity just happens to be the least bad proxy we have of things happening in a person's life, and a range of things happening underneath it. So this may be a signal, but it's certainly not a prescription or a cause. So yeah, that's just a simple chart to show you, that link. And clearly you can see, we know there's going to be a link here, but you can see how steep that line is as well. So it really gives you a kind of a real-time patient level, named patient level indication of who, not just that this matters, but you're starting to see that these are very simple signals on a patient's record to show you who's rising risk or who may have unmet social needs. So that's a quick whiz through, kind of what are the main needs in your population, every population, nationally, arguably internationally. The second question I wanted to answer is what interventions have the biggest impact on health and demand? There's a litany of great data now. We're getting new information through every week. So I can't, I'm going to do a real disservice to the range of different projects that I'm going to summarize here. And I'm happy to provide more information on this offline as well. But so the four things on the slide that are kind of increasingly well researched as having an impact both on health and now on demand, trying to create this link between population health and demand management as well. And the reason, and one of the key reasons why we make this link is because I think that making the case for doing more population health improvement is implicit, and it makes a lot of sense on a personal level, on a patient level. But I think that the missing ingredient is trying to show that these kinds of interventions pay for themselves in demand reduction as well. So when we're talking about health coaching, what we know is from really strong research that we've done is around 2 health coaching contacts can be responsible or are correlated to a reduction of 12 primary care appointments, with corresponding large reductions in BMI and other health metrics like blood pressure. When we're looking at social prescribing, we know that 3 social prescribing contacts are correlated to a reduction of 4 GP appointments, with more modest reductions, but albeit there are still reductions in BMI as well. With practice nursing, we know that the more times a patient sees a practice nurse, the less they see their GP the year after. And when it comes to lifestyle nudging, I'll go on to this in a little bit more detail because this is really critical. Lifestyle nudging offers an approach that lets us tackle the very, offer some sort of support to the very large number of people who may benefit from it, because things like health coaching and social prescribing are one-to-one or one-to-few style interventions. They're hard to do on a one-to-many basis because they're more intensive and in that respect. So what we're saying here is that the key message here is I love health coaches and social prescribers that I've worked with, and care coordination and clinical pharmacy and new to practice GPs as well. But this isn't an advert for those roles at all. Well, it is a little bit, but what it really is an advert for is what's the link, what's the common thread behind all of these roles? And the common thread is proactive, personalized care. What I often say here is it doesn't matter who does it. All the best interventions, the interventions that have the biggest return on investment, they're kind of personalized care in disguise, and anybody can do it. So holistic care is key, and every contact really does count. And so this slide just shows you quite how important relationship-based lifestyle education is, and the relationship is really key here. But and so this is a chart. What the chart is showing you is on the x-axis is the number of times a patient has had any form of lifestyle education, and this is driven by a lot of GP data. And on the y-axis, it shows you the drop in GP contacts the year afterwards. And in summary, what the chart is showing you is the more lifestyle education a patient has, or the more lifestyle nudges a patient has, the bigger the fall in demand and the bigger the fall in BMI the year afterwards. So not 2 years later, the year afterwards. So the reason why this is so exciting is because it takes what we're learning in those more intensive interventions, from health coaching to social prescribing and care coordination, and it's saying if we do kind of the same thing but at a smaller level, but in every contact, this can have a remarkably big impact on patients, but potentially a more effective return on investment or ROI. So it's really trying to make the case for how do we support the very large numbers of people who fall into these need categories, and so we're not just focusing on those who, the intensive support for those who kind of really, really need it. So, and we've got more examples around using Accurix text messaging in diabetic chronic disease reviews to really amplify the support, and a whole range of other examples as well around how just adding lifestyle education and nudges to your existing work can really have a great impact. So the final thing I want to chat about is, how do you get started? I'll just whiz through this. There's a lot of detail here, but effectively, the top left is the key. Really, is it's about saying how much energy do you have this month to do something, and if you don't have that much energy, just choosing a group of patients or even one patient to start with, just to start that ball rolling. So it's, we often say that, all the big care model stuff that I've evaluated in my career, when you peel away the layers of the onion, you always find that it started with one passionate person doing one thing for one patient. That started the ball rolling. So if it feels hard, don't try harder, make the project smaller, start really small. Obviously focus on prevention, so getting as far away from, or getting further upstream from acute need as possible. As you've heard others describe, involving others isn't an add-on anymore. The voluntary sector, other providers, when we're talking to primary care, involving others and particularly involving communities, as Dan described, is now the spine of any of this work. What we say is the data or the targeting sits in primary care, but the work is often done by others, but primary care can be the main beneficiary in terms of demand reduction. So that's really key. And then the final thing is it's critical to measure something. What should we measure? And you've heard it from others already as well, but health confidence, self-efficacy or patient activation is really, really critical. It's the key. There's a 13-question patient activation questionnaire that you can use. There's a tool, and if you're licensed to use it, it's great. But sometimes social prescribers have said they've struggled to get patients to complete the tool. So we're finding learning about patient activation just by asking a single question, how would you rate your ability managing your own health and well-being, works pretty well too. And what the chart shows you is that patients not able to manage their own health and well-being see their GP 10 more times a year, but when confidence improves, then it's only a matter of time before physical health improves and GP contacts fall. So activation is a really great thing to capture. So you're making sure you're delivering the right intervention, number one, but it's also great to capture because it gives you a really easy and quick way to measure whether you're having an impact. So I mentioned on the previous slide, you can start a project with just one patient. If you took one patient from a deprived postcode with low clinical complexity, for example, and you supported them with social prescribing, you ask them, how would you rate your health and well-being? And they say it's a 1 or a 2. And if you found that after 3 months or a month or a bit of support, that rises by 1 point, a 1 point increase on the activation scale can save the NHS up to £520 in terms of reduced primary and secondary care demand in 1 year. And that's not counting patient benefit or the benefit to other providers. So if you keep that 520 figure in your mind, if the support that you provided to patients was less than that, you can do a very quick return on investment calculation to see whether this work is worth continuing with. And that's this is the kind of evidence that really can bring naysayers or people who are critical of this work on board, because the patient benefit is implicit, but then this is now becoming something that's more about helping make the NHS more sustainable. That final question too is really critical to a really good behavioral change, motivational interviewing approach, but also if you aggregate answers to what's the one thing patients needed, that can help you focus your support. And you will often, when you ask this question to 30 patients, you'll find transport very high on the list and relationship-based befriending services very high on that list as well. So it just helps you take an evidence-based approach to the litany of different resources in your area to focus on what's the thing that patients really need to remove blockages that are in their way to managing their health and well-being better. So finally, to summarize everything that we've learned from the large number of projects we work with and all the data that we've looked at as well, this sentence really just summarizes it all in one sentence. The interventions that have the biggest impact on our populations are ones that help us move, eat better, sleep, and connect with ourselves and others. When we're talking about social determinants, we have to address those things to enable people to do these things more. So this is not about housing and poverty. They're things that get in the way of helping patients or helping people do more of these things. And if you want to do one thing to get started, just start by measuring health confidence. Thank you.
Thanks so much, Jag, for that really great presentation.